current landscape of cellular therapy, I think, is an exciting one. I think we are seeing in multiple myeloma the prospect of CAR T-cell therapy being approved in the near future. And I think that, well, this will be the first CAR T or CAR product of any kind that will be approved for the treatment of multiple myeloma. So this will be a landmark achievement. However, despite the great promise that CAR T cells hold in multiple myeloma, it unfortunately is still the case that they do not appear to be curing anybody, and they are quite a complicated, labor-intensive, logistically challenging and expensive treatment to deliver. And so, there is the argument that for something that is so expensive and difficult to deliver, if it's not actually, curing patients, whether this is the model that we should be following in the future. And I think this is leading to a greater interest, for example, in off-the-shelf bispecific approaches, bispecific antibodies, which I think we'll hear a lot about at this meeting, but also in alternative forms of allogeneic, potentially off-the-shelf therapy. So at the meeting, we are going to hear something about initial treatments or initial results using allogeneic CAR T cells. But these do require quite a bit of engineering because T cells have the potential, when used in an allogeneic form, to cause graft versus host disease. So this has led to an increasing interest in the potential of natural killer cells as an alternative driver for CAR cell therapy in multiple myeloma and other cancers. And so within the scientific workshop, my remit was to give an overview of where CAR NK cells could potentially fit, and NK cells in general fit into the treatment landscape of multiple myeloma. It's a little bit challenging to do at the present time because we don't yet have any data in the clinic with CAR NK cells for myeloma. So the best we can do is look at what has been achieved with non-modified NK cells or NK cells in combination with monoclonal antibodies, and to extrapolate from the very exciting results that were recently published in the New England Journal of Medicine in the context of B-cell lymphoma using CD19 CAR NK cells, the very fine pioneering work from Katie Rezvani at MD Anderson. And if we go on that, on the promise of what she has shown, I think we could envisage in the not too distant future the CAR NKs in multiple myeloma making quite a significant impact due to the ability to use them potentially as an off-the-shelf product, the fact that they don't have any potential for graft versus host disease, that to date they have not been associated with cytokine release syndrome or with neurotoxicity. And because I think ultimately, given the ease with which they could be manufactured as opposed to an autologous CAR T-cell product, the likelihood that they could be available at a greatly reduced cost. Another factor, of course, is that NK cells do have an innate ability to recognize and target transformed cancer cells. And so independent of any target antigen that might be the target for a CAR, NK cells do have an ability to recognize and kill. So that in the event that a target antigen is lost, and we know that antigen escape is an important mechanism for immune evasion and resistance with CAR T-cell therapy, that this could be an added advantage for NK cells. But then, of course, NK cells are now being engineered to provide further modalities, such as additional CARs, the ability even potentially to target the apoptotic pathway, the death receptor pathway using trail variants, potentially combining a CAR with monoclonal antibodies because NK cells do express the CD16 Fc receptor for antibodies, and a host of other potential modifications that can be engineered into NK cells to give them the edge against treating an elusive disease like multiple myeloma.